All right. Hello, everyone. Welcome to Ocular Pathology Rounds on this day, March 22nd. Today is very exciting. We are going to introduce and do an orientation to our brand new Ocular Pathology Online Atlas. And I announced it 2 weeks ago as well, but this is a pretty exciting thing that we're ready to reveal. And Ryan Taylor had a lot to do with its birth and development up to this point, and will continue to have a lot of influence on the cool stuff that gets uploaded as we go. But so I will now let Ryan take it away.
For sure. Okay, so the Atlas is not live right now. So we did not post a link to it right now because we were fearful of everybody trying to log on at one time and then us not being able to present. So either later in the day or possibly later in the week, there will be a link that will be posted on Coplow's website. Dr. D will likely post it on Facebook as well for some of you guys. The link is going to be really long because it's subdivided and buried into all these different platforms. So the link is going to be really long, but it will be available. No login will be necessary for it. You will click on that link and then it'll take you directly to the atlas that we have developed. And then you'll have full access to it. And so if you do have any problems, you can email Coplow about it. We are partnered with right now Vet Derm Path. So thank you for Vet Derm Path for allowing us to piggyback off of you as well. So the link will say Vet Derm Path on it because we are using a subsection of something that they have already developed. But they have allowed us to have our own little section of it that's developed nothing to ocular pathology. So it will say Vet Derm Path on it when you click on the link, but do know that it will take you to the ocular pathology portion of it. And so with that, I am going to open up the Atlas now and do a walkthrough with you guys. Can you still see my screen, Gillian?
Yep.
Great. So when you log in, this is the first thing that you're going to see. I have logged in through the link. So everything you see right now is how it will appear to you. When Gillian and Kelsey get on in just a little bit to present a case, they will probably be logged in through their administrative access. So there'll be more little buttons that they have that are available that will not be available for you as a viewer. So they have freedom to edit. You do not have any freedom to edit at all. Okay. So thank you for Coplow, Dr. D, Gillian, and Leandro for the support through all of this. Without Coplow, this would not have been able to have been done. So thank you for funding it, and thank you for providing all of the cases. The way that the Atlas is organized right now is it's pretty much verbatim of Dr. D's book. So these are mostly the headings that are present within Dr. D's book as well. The exception to that is I made a specific category for manifestation of systemic diseases. And then I also made a category for diseases of the vitreous. This is a growing atlas. We're probably going to change some of these categories. The diseases of the vitreous aren't actually specific vitreal diseases, but it's things that manifest with more vitreal lesions histologically. And that was the best category I knew to put them in right now. So as we start talking about the atlas more and adding more cases to it, some of these categories might change. We will be adding more cases as time goes on. So stay tuned as life happens and more cases will be added to it. We do have a brief disclaimer that's present here as well. If you read between the lines to it, it's basically saying if you use this for other purposes, you're using it at your own risk. This is not meant for anything for publication or profit or for research. So we're fully aware people are probably going to use this for their cases, but do know that you're responsible for your own cases. Okay. There are a list of normals that are here at the very beginning. Thank you, Gillian, for editing all of these. And so normals are available for you. We're working on adding a horse normal as well, and we'll likely add more cats and more dogs to it because there are variations to normal throughout some of them. And in a little bit, I'm going to talk about all these little black lines that are on there. So that'll come up in just a second. I'll show you guys how to do that. So once you get through the normals, there'll be a section that's actually mystery slides. And the reason we added this in here is because right now, when you go through the Atlas, the answer is given to you as soon as you click on it. But if people want to quiz themselves without knowing anything about it, we've started making some mystery slides that are in here as well. Most of these right now are copy and pasted from things that are directly in the subcategories of the atlas. And that's true throughout other things, because there's certain disease entities that fall under uveal disease that also might fall under lenticular disease or something. So some cases are used more than once, and that's just because of pathogenesis and what lesions might be available. So if you do want to do mystery slides, those are present here as well. And then getting into the actual portion of the atlas. And I'm going to start with a case. And we will start here. So things that will be available for you and how to navigate and go through the atlas. Once you click on the image, and that could be a gross image, or that could be an actual histo image, it will appear before you on your screen. If you want to make it full screen, there is this little sideways hamburger, if you will, and you'll click on it and the tab will go away. This is as full screen as it gets. And if you want to bring it right back up, you can click this tab here as well. Things that are available for you at the top of the screen, you have the option of zooming in with the actual triggers that are here, but you can also just scroll with it as well, which most people are probably just going to scroll because you have a mouse. If for some reason you get lost on the slide or the zooming isn't working, you hit this home button and it kind of resets to the normal zoom. Depending on how things were scanned in or how they were put on a slide, they're going to appear in a different orientation. One thing I really like this is you have the freedom to rotate it 360 degrees. And so rotate it in whichever direction that you want to. The other thing that'll be available for you is you can take snapshots. And so anywhere you want to, you can control the size of the window that you want to do for the snapshot. You will click the button here in the center, and it will immediately download as a JPEG, I believe, with a file name associated with this case, and it automatically puts in a scale bar. The scale bar is kind of awkward sometimes on like where it shows up, so you just have to play with it. That way you know where the scale bar shows up. There's no way to not have the scale bar there. So if for some reason you don't want the scale bar in an image you're taking a picture of, just take a little bit bigger image and you can crop the scale bar out. Or if you're fancy with Photoshop or something, you can edit it out. The other really cool thing that is available in this atlas is you can actually do split screen viewing. And so let's say you're looking at this gross image right here and you're like, wow, that's really cool. I wonder what the histo looks like. There will be an add a new viewer that will be present up here in the upper left-hand corner, and you'll click it. It's always going to appear as the very first image in the atlas at first. So this is the very first image that's in the atlas. But you can change it by clicking on this window where that is, and then clicking on the slide that you want to appear. So if we look over here in the left-hand side, we can see that there are two separate things that are selected. The one that is in yellow right now is the one that I have selected on the screen. And so if I click the gross image, you will see that yellow bar change. And if I click back, you'll see it go back and forth. And the reason I point this out is because I actually like the gross image on the left-hand side for some reason. I have no idea why, but I do. So if I want to change the image that's on the left-hand side, I will click that, and then I will click the image that I want it to be. And then for whatever image I want on the right-hand side, I will click that right-hand side image, and then click what I want it to be. For some reason, I like the gross on the left side. You do whatever you want to. With how most people photograph their ocular lesions, and with the majority of lesions that we photograph at Coplow, the gross image is going to be a direct correlation to how it's showing up on the slide as well. So left should be left, right should be right. In the sense of like on the screen, not necessarily the left side of the globe or the right side of the globe. But dorsal should be dorsal, ventral should be ventral on how they work out and how they're oriented. The exception to that is if we go back and take an image of like the other half of the globe, then the orientation is going to be a little bit different. But for the majority of our pictures, the way you see it in the gross image is the way that it appears on the slide as well. Other things that are going to be available for you is there's this little annotation icon, which is an eyeball. And when there's no slash through it, it means the annotations that we have added to all of these slides, that being gross and histo, will appear for you. And you can hover over them and click on them, and there'll be a brief little description of what we're trying to point out in that general area. And that's true for on the histo slide as well. If you click on them, there'll be a brief little description of what we're trying to point out to you and why we're pointing it out. Did we mark every single lesion? Probably not, because every single eye typically has intraocular hemorrhage, and I got tired of writing intraocular hemorrhage on every single slide. But we're trying to point out the salient features, the key histologic features to help you get to the diagnosis. Some of the small ancillary things like stromal vascularization in the cornea is probably going to be missed on a few slides, but most of the salient features should be present. When you're ready to get rid of one of the additional viewers, what you will do is just click on this small little X associated with the one that you want to get rid of. So once you click on it, it goes away. The annotations, you can toggle back and forth. So if you want to work through the slide by yourself at first, you just click on that eye, all the annotations go away. They will not appear again until you tell them to reappear. So once you push on it again, the boxes will reappear with what we are trying to highlight. The other thing that is available for all of these is the metadata that is embedded within every single slide. The very first part, no one really cares about, so I'm not going to talk about it. You can make it small. But then we have the case information that was given to us. So we have signalment and history. For most of the histories, I tried to put as close verbatim as what's given to us on our forms. And the main reason I did that is I want you guys to see the types of histories that we get. And there is a wide variety of different histories that we get, from some of them saying globe to other ones having really extensive, well worked up eyes. And so there's a wide variety of clinical histories that you will see present throughout as you go through these. And most of that is history as it is written directly on our forms. So we will tell you the laterality of the globe. So if we know left or right, we will definitely specify that. There are a few where the clinician didn't tell us, and so we'll just write unknown in there. The tissue that's provided, most of the samples that are in this atlas are globe, but sometimes we get orbital tissue, sometimes we get conjunctival tissue or eyelids. So the tissue that was provided is also going to be there, and then the signalment of the patient. If glaucoma was reported, we will mention that as well. And if they told us IOP, we're putting that in there. And then if they told us the status of the other eye, that is also included. Gross findings are findings that we see when we're trimming the eye that you can't see well histologically. And the biggest examples of that are going to be vitreal degeneration, ophthalmos, and lens position. Most other things you can see pretty well as you are going through histologically. So if there is something in the gross findings, it's mostly going to be if we thought the globe was ophthalmic, if we thought the lens position was in an odd position, whether being subluxated or completely luxated, and the consistency of the vitreous. If there's nothing written there, then we didn't think there were any obvious gross findings that you couldn't see histologically. Okay, there's another thing in here that says case attachments, and I will jump to another case in just a second to show you what that is. And the other thing that's available down here are all the annotations that we've done. The way we've done the annotations is we try to start with kind of a leading description, if you will. And so pointing out retinal detachment. And then there's a little description behind it. So when you click on that annotation, it will jump directly to the annotation that we were pointing at the magnification that we made that annotation. And so if you want to see the corneal stromal vascularization, because for some reason you're interested in it, you click on it, and then it'll take you to the annotation that we talked about for the corneal stromal vascularization. If for some reason you're really struggling finding organisms, there's probably a little one in here that highlights organisms. And so whenever we find small things that are present as well, we do our best to highlight them and then do our description with them as well. So that's the basics of how to navigate through it, the tools that will be available for you, and different ways that you can use some of those tools. I'm going to jump to a different case real quick to show you guys what the case attachments are and how you can utilize those. So give me just a second. Okay, so this is a case of xanthogranulomatous endophthalmitis. I'm not going to work through the cases that I'm presenting. I'm just trying to give you guys a general overview of how to look at it. If there are some photomicrographs that we have taken for any reason, so the reason we did this one is because it was something that was able to be polarized. When you click on these, it will download it as an attachment. That's just the way it works. But you can click on it to open it to see what it is that we had. Remember, these are being downloaded, so if you don't want to have a lot of them on your desktop, be sure to delete them afterwards, or if you want to save them, feel free to save them, I guess. So if there are any other things that can't be shown really well on the scan slide, there are going to be some photo mics that pictures have been taken of that you will have access to as well. The other thing we've started adding in here are journal articles that support the diagnosis. I've never clicked on the journal article. Okay, so it will also be downloaded. And that way, so the journal article that Dr. D did back in the day of xanthogranulomatous endophthalmitis in miniature schnauzers has been connected to this. And that way, you don't have to go search for the article. It will be present right there for you. Once again, though, it's being downloaded. So remember that this is being downloaded onto your computer. The other thing, one more thing to mention, there are some cases that have bilateral lesions. For those cases, typically what we have done right now is that there is a histo description for one of the sections, but maybe not for both of them. And that's usually because of the symmetry of the disease associated with those. So I'm about to do a split screen view. So we can look at the left globe, and so we can look at the right globe. By globe, I mean evisceration sample in this case. But the annotations that are present here are just done for this right globe or this right evisceration sample. And we don't really have any annotations here on the left one. The main reason we uploaded these is typically to show symmetry, or if there's bilateral disease, whether that be in VKH, fungal infection. For some reason, we had a case of gonio, and then years later, we got the next one. We're working on uploading cases that we have bilateral globes for. So right now, it might not be present for all of them, but in the future, that is something we plan on doing, is uploading the additional globe to these cases as well. Other things that will be present if we have it, if we did special stains that help with the diagnosis, Gillian's going to show one of those. The special stains have also been scanned in. If we have access to the IHC that was used to help with the diagnosis, the IHC slide is also scanned in. If we didn't have access to it, then what I've done is I've tried to take pictures of the IHC of where it was done and uploaded a picture to it of the IHC. That is the basics of the atlas and how to use it, how to navigate through it. There are a lot of headings in here right now that do not have something with them, like microophthalmia of white-tailed deer. If you click on this, nothing shows up. That's just because we haven't added it yet. I went ahead and created all of the headings and all the titles for things that I know we want to add, just to make sure we don't forget things. So in the future, there will be slowly new cases that start to trickle in. So slowly, these tabs will start to be filled up with more and more cases. And so that is all that I have. I tried to do it in 20 minutes to give Gillian and Kelsey time to actually present cases on the Atlas. Does the Coplow team or anybody in the audience have any specific questions on navigating through the Atlas, or was there anything that was confusing on how to use it? And we can try to address it right now.
I actually missed the part where you said how to make it split screen. Can you show that again?
Yep, I will
I
show
missed
that
it a second time.
That's fine. So we will go to a case. I'll go back to the case with the gross image that I was using. That way you can see it change a little bit better. And so if you want to do a split screen, up here in the upper left-hand corner, there's a little monitor with a plus to it, which lets you add a new window or add a new viewer. When you push that, the image that's going to appear is the first image that's in the Atlas, which is always going to be this little logo right here. But you can change it with what you want it to be. And so I want it to be this histoslide. And so I clicked the histoslide down here. You can also alternate which side it is. So over here on the left-hand side, there's a yellow box and a white box for the two things that we have viewed right now. The yellow box is the one that you have selected on your screen, which means this is the one that is active right now. If I click the eye, the gross image of the eye, you will see this yellow box change over here on the left-hand side to where now it is the eye, the gross image of the eye that we're able to manipulate. So if you want to switch from left side to right side for whatever reason, you click on the side that you want to change. So I want to change this histoslide to the gross image. So I will click that. I will go to the gross image because that is what I want it to be. And then it will appear. So you can have the same slide duplicated for whatever reason, but you don't need to do that. And then on the right-hand side, I'm going to want it to be the histoslide. So I will select that right there. And this yellow box indicates to me that I have the right side of my screen selected. And with whatever I want to put over there, I can now select something else, and the histoslide will appear for it. There's no way to link them in the sense of like, as you zoom in on the slide, it automatically zooms in on the gross image. That does not happen. You are able to have at least up to 4. I know, yeah, so you can only have up to 4. So if for some reason you want to have 4 separate images that you're looking at side by side, but the screen gets really busy then, but you figure it out as you go through it if that's something you like. One other thing to point out, so thank you for that, Gillian, is there is this little image in the upper left-hand corner that you will always have control of, and there's no way of getting rid of it. So accept it, it's there, it is your friend for life. But the benefit to this is if you want to jump to an area on the slide, you can click on this sub-gross image, and it will take you to a new position. So if you want to leave it up there and you're tired of scrolling around and you want to quickly get to the optic nerve head, you can click on that sub-gross image and it will take you directly to where you're clicking on that sub-gross. And now with that, that is everything that I have. Okay, I am going to stop sharing my screen if there's no more questions. Gillian and Kelsey have some cases prepared that they will demonstrate through the Atlas and actually walk through the entity, whereas I just kind of gave you a general overview of how to use the Atlas and navigate through it. So Gillian and Kelsey, I will stop sharing, and it's up to you now.
Okay, so now we do this. Right? All right. Okay. So, I will go ahead and show my chosen case, which is here, and then here, and then let me make my thing bigger so I can read it. There we go. Okay, so there is no gross photo associated with this, but there is a nice histo, obviously. So this is a post-cataract surgery case that also has mycotic keratitis, so it took away my thunder, I guess we could say. But anyway, so this is an 11-year-old neutered male miniature poodle. And the history we got was that there had been cataract surgery, phacoemulsification bilaterally about 3 months prior to the enucleation of this eye. And this eye was being treated for keratoconjunctivitis sicca or KCS. This eye unfortunately developed a corneal ulcer with reflex uveitis about 1 month post-operatively, and the ulcer became non-healing and non-responsive to corneal debridement, which was diamond burr and then grid keratotomy about 2 weeks apart. And then it recently developed secondary glaucoma. So the patient also has diabetes mellitus and Cushing's disease. So they had diagnosed glaucoma prior to enucleation. The IOP was 33. The other eye, all that we got was that it was pseudophakic, but doing well. And the only thing we noted grossly that we couldn't necessarily identify on the slide very easily was that an IOL was in place, so an intraocular lens. That's the fake lens that they implant after cataract surgery. I don't think there are any case attachments for this one. And so that's all the metadata that we'll go through. But anyway, here is our globe. And in the subgross view, one thing that you can really note very obviously is that the lens is not there, or is not very obvious. I'll point out that what we have here is actually the lens capsule, and the IOL is in place, and you can actually see it when we go a little bit higher mag. It is a colorless, slightly refractile object, and in this case, it was in its proper position, which was, first of all, in the posterior chamber, and second of all, within the lens capsule. So this dog and this eye had a pretty significant corneal history, and then secondary glaucoma. So we will zoom in here. So here's the cornea. There's a little bit of artifactual wrinkling going on, but you can see the corneal epithelium comes along here, and it actually becomes detached from the corneal stroma in this area. So there's a subepithelial cleft formation. And then you might think that that epithelium is what is continuing across this area, but I will tell you that's not actually the epithelium. That is a little bed of fungus, which is really exciting. But the corneal epithelium is hyperplastic. It's definitely too thick. And it's a little bit keratinized. You can see how these keratinocytes on the surface are becoming flattened and brightly eosinophilic, which is a sign of keratinization, which is abnormal for the cornea. In this area right here, as I said, the epithelium becomes detached. And within the detached segment, at least in this area, the normal organization goes away. So it has lost its polarity, is what we say. So if we compare that over here, we have decent basal layer, and then the cells get slightly bigger in the middle of the epithelium and then become flattened on the surface. That's normal maturation of any stratified squamous epithelium. When we come over here and when the epithelium becomes detached, you lose that nice basal layer and you lose that nice organization. And so that the cells become a little bit jumbled. Sometimes it forms little eddies. So this is an eddy right here. And that's an indication that this is a true epithelial detachment, or yeah. And so if the epithelium were intact diffusely in this area, like all the way across this area, it would simply be a subepithelial cleft. And if it is torn, as it is here, then it's actually classified as an indolent ulcer, because then all of a sudden the epithelium is absent in an area, hence the term ulceration. Also in this area, we can see there are some islands of epithelium within the superficial stroma, and that is indicative of an collagenolisis. So there is keratomalacia here. The stroma of the cornea is degrading, and that leads to sort of epithelium dropping down into lytic stroma. And so that's the hallmark feature that we look for. Obviously, in this image as well, there is heavy vascularization of the corneal stroma. So there's vascular formation. In this area, we also have heavy neutrophilic infiltration. And then when we get into the ulcerated area, which, remember, this is not actually the epithelium, we'll go higher mag in a sec. One thing that you can note at this magnification is that from here to here, that corneal stroma is completely acellular, and it's maybe mildly hypereosinophilic. So this is an area of corneal stromal necrosis, in that there are no viable keratocytes left. And so remember that the stromal cells of the corneal stroma are called keratocytes, not keratinocytes. To be slightly confusing. Anyway, so as we zoom in, we can see this beautiful mat of fungus. And this is as high as we can go on this image. But what we have is a bunch of little individual yeasts. And then rarely in the stroma, let's see if I can find one. Sometimes they actually form little hyphae, which I believe are pseudohyphae. And there was a good example, but I don't know where it went. I found it last night.
Is it annotated?
No, I don't. Oh, well, we can check. I don't think it is. No. Anyway, so in the stroma, they occasionally form pseudohyphae, and actually right here, there are some elongated ones. So this morphology is really characteristic of Candida. So chances are this is going to be a Candida organism here. Which is actually fairly rare. We actually don't see this very often in the cornea. So this is pretty cool, a pretty neat case. Anyway, we did not find bacteria to go along with the Candida. But there's the mycotic keratitis, not mitotic. All right, and then just real quick to show you the special stain, I'll show you the rest of the lesions as well. But here's a PAS, which is kind of a funky one, but it's very dark, the PAS part. This is probably an Alshan blue PAS. And so our little yeasty beasties are staining pink with that PAS stain. And actually here you can see maybe some of those pseudohyphae in the corneal stroma. Another thing the PAS stain shows pretty nicely is Descemet's membrane. It's very dark in this image and in this sample. I'm not sure exactly why. Normally it's slightly more pink. Here it's just very dark purple. And so this globe had cataract surgery. They typically do the incision for cataract surgery in the dorsal peripheral cornea. And so here, this PAS stain nicely highlights that break in Descemet's membrane. And there's a little bit of a stromal reaction here, which is pretty typical, that you end up with a little bit of corneal stromal fibrosis in the area of the incision. And then here, it also highlights the nice nicely highlights the lens capsule. And here, once again, you can see that the anterior lens capsule, which is always the thicker one, or the thicker area of the lens capsule, is discontinuous. So when they do cataract surgery, they come in and they do an anterior capsulotomy and they cut into the lens capsule there. And then they're able to stick their little probe in there to suck out and liquefy the rest of the lens that may not have been liquefied at that point. And they do all that, and then they insert the intraocular lens, which actually you can see nicely, kind of outlined here with this special histochemical stain. Most IOLs these days are soft, and so they're easily cut through on the cutting board for us when we're grossing a globe. And then also histotechs can also cut through them very easily. Some of the older ones, there's an acrylic lens that is probably older, but also it's still used occasionally for various reasons, which I don't know. But if you happen to encounter one, good luck cutting through it with your blade. If you're unlucky, you will completely seat your blade in that lens and not be able to cut all the way through it. And then you'll have to pull that lens out, stuck to your blade, mangling the globe as you go. But anyway, so let's go back to our H&E. And we'll continue the tour of this globe. So remember, they diagnosed secondary glaucoma. So let's see if we can figure out the cause of that secondary glaucoma. And what we have here is a beautiful pre-iridal fibrovascular membrane. If we zoom in closer, you can see the blood vessels in there. You can see all the spindle cells that make up that fibrovascular membrane. And then there's also some inflammatory cells. So you can see some of those inflammatory cells in the iris stroma. So we have a mix of lymphocytes and plasma cells, and there are probably some macrophages here and there. And some inflammatory cells like to mingle with the PIFM on occasion, or multifocally, I should say. And there's a few red blood cells in the anterior chamber. As Ryan says, most of the globes we get have some sort of hemorrhage in them. And then you can see that pre-iridal fibrovascular membrane crossing the irido corneal angle and attaching sort of right to the end of Descemet's membrane. So this is forming a peripheral anterior synechia, which provides a nice explanation for decreased aqueous humor outflow and thus the glaucoma development. Another thing you can appreciate here is that the trabecular meshwork, which should be right here, is quite collapsed. And also it has some melanin-laden cells in it. So this is an example of trabecular meshwork pigment dispersion, which also contributes to decreased aqueous humor outflow and glaucoma. So let's go over to the other side and look at this other side. So once again, there's a little bit of that hemorrhage. You can see it lined up on the ciliary body surface here, nestled between the ciliary body plica and the back of the iris, and a little bit here in the anterior, anterior chamber in the ventral iridocorneal angle. And so here's that nice PIFM again, pre-iridal fibrovascular membrane. Let's move over to the lens capsule to talk a little bit more about that. So you saw it's on the PAS stain. What we have here is some remaining degenerate lens fibers. So here's some lens epithelium that still remains after the surgery. And then here we have some degenerate lens fibers. These are some Morgagnian globules. This guy right here has a nucleus, so he could be classified as a bladder cell. And then also you can see that there's quite a spindle cell proliferation that's sort of continuous with that lens epithelium. And so more than likely, this is an example of fibrous metaplasia of the lens epithelium that actually has formed a membrane that continues right out of that lens capsule. Now, I can't guarantee that this is that this part right here is only lens epithelium, and this because it's possible that this originated outside of the lens capsule and then grew into the lens. So this may have been part of the pre-aerial fibrovascular membrane, or at least the anterior chamber membranes that formed. Other things we can see are the lens epithelium that has become spindle cells. So this is epithelial to mesenchymal transition, also known as fibrous metaplasia of the lens epithelium, has migrated posteriorly and is now lining that much thinner posterior lens capsule. So that is one of the hallmarks of cataractus degeneration. So posterior migration of the lens epithelium. And you can also see that the posterior lens capsule is wrinkled. This may have predated the cataract surgery or developed afterwards. As I said, you can kind of make out the IOL. So here it is. You can kind of make out that little thing. If this were a slide on your microscope, you can actually stick your finger between the light source and the slide from the bottom to cause a little bit of digital polarization, and that usually highlights an IOL very nicely. Other things in this eye, so the most exciting thing, and then I'm almost done with this case, is that there is evidence of glaucomatous degeneration. So as we move up and look at the central retina, you can see that very few ganglion cells remain where they should be in the ganglion cell layer area. This eye also has some very interesting outer nuclear layer disorganization. So these are the nuclei of the photoreceptors. They're forming sort of rosettes or pseudo rosettes, whatever you want to call them. And that's just a degenerative change. In this case, we're not quite sure why it occurred. This can be seen with congenital retinal dysplasia. So it is possible that this dog had congenital retinal dysplasia. It's also possible and perhaps more likely that this is some sort of degenerative change associated with the stuff that's happened to this eye. Occasionally, we will see this with in eyes that have had intravitreal gentamicin injections. Let's see here. And then also we have a little bit of central full thickness retinal atrophy on this area. And remember that our, oh, I should have done that a long time ago, sorry. Remember that the surgical site incision was on this side of the globe up over here. And so this is the dorsal or tapetal area of the retina. And it is artifactually detached in this area. But it is also a little bit disorganized in the outer retina, and no ganglion cells remain. And then when we look at the optic nerve head, the lamina cribrosa is actually all the way recessed back here. And normally that should form a straight line across and be at the same level as the choroid. So we definitely have optic nerve head atrophy. And we didn't sample the optic nerve very well because this is a little bit of a peripheral section where you can see the pigmented cells in the meninges coming through here. But the optic nerve is probably a bit gliotic as well. So those are the features of this case. These features are not unusual in our hands as far as post-phaco emulsification eyes after cataract surgery that end up in jars on our counter. So they often will develop secondary glaucoma, and that is the reason why they're enucleated and sent to us. I'm not saying that all cataract surgery eyes end up with glaucoma. That's what I'm trying to make a careful point. But we are biased as ocular pathologists because that's all we see. Anyway, I hope that most of them are successful in the long term. Okay, it is now Kelsey's turn.
While Kelsey gets her case up, I just want to mention one other thing. Sometimes the Atlas struggles loading a slide. It doesn't happen often. So if for some reason it doesn't load it, just refresh the window. I have found that to help like 99% of the times. Sometimes I have to close out and reopen it. But typically if you just refresh the window, if it's acting kind of sluggish, it'll pick back up.
Okay, we are going to do a case of hyperviscosity syndrome. As Ryan explained, the ending gets spoiled real fast when you're using the Atlas, but that's okay. Okay, so we will start with the gross image and then make this real small. I'm actually going to turn the annotations back on just so you guys can have some practice seeing how the annotations work. So here's our gross image. As always, in all of these pictures, cornea is at the top, although You do have the rotation option if you decide that you find it more aesthetically pleasing to imagine that this is the dog looking to its right. You can rotate the image to the right. Now the cornea is over here. It makes Leandra really uncomfortable, so we'll just put it right
That
back
was
where
weird.
we had
I
it.
didn't like it.
Here's the lens. And then we've got all of this material inside of the globe, and you may be asking yourself, what could that material possibly be? And if you want to know, you can click on the circle that is surrounding the material, and we'll get a nice little dialog box that will pop up and tell you that we've got this opaque subretinal fluid. So this is really jelly-like when we cut into it grossly. It like literally is like the consistency of Jell-O, but usually more opaque than Jell-O is. And then accompanying that, we also have these areas of hemorrhage. Some cases of hyperviscosity syndrome have more hemorrhage, and some cases have less. And then we've also got this tissue that's kind of coming up like a trumpet flower from the optic nerve area. We don't have optic nerve in this section, but from the optic nerve area and then surrounding the lens. And when we click on that annotation, it tells us that this is the detached retina with some associated intraocular hemorrhage, which is all this bright red material.
I have a really goobery question.
Gillian has a goobery question.
And it's maybe really dumb, but I'm assuming this stuff is solid when we get it after it's been formalin fixed.
Mhm.
Is it solid when it's in the eye, or is it liquid?
This is, I assume, a clinician question.
Well, yeah, does anyone know? Is it the formalin that makes it solid?
My sense would be, oh, go ahead, Leon.
No, go ahead.
Oh, my sense would be that it's like any other like densely proteinaceous fluid. Like, you know, like you see FIP and you've got like the densely proteinaceous fluid inside of the body cavity. And
Okay,
like,
yeah.
you know how you drop that into acetic acid and then it gels and congeals? Formalin's also an acid. And so
Yeah.
my assumption is that when you put it into the acid, it gels and congeals in the same way.
Okay, that
Formalin
would make
does
sense.
fix things is to create bonds between proteins.
Yeah.
Okay.
So I think the protein rich content there, when you fix it in formalin, it gels because the formalin creates bonds between the proteinaceous content of the fluid.
Okay, as I said, that was probably a dumb question, but
No,
if anyone else had it, now you know.
Yeah, Aaron Scott responded and said it's a dense liquid, but I kind of agree with you guys. I think once it sits in formalin, it bonds together a little bit more. I think the best example is like an FIP in the brain, because typically when you cut a brain of a case with FIP, that stuff leaks out relatively readily within the ventricles, where if you let it fix first, it normally forms a nice little more substantial gel, if you will. So yeah.
Does anybody remember the thing that you learned about for NAVLI where you take a drop of FIP
Revolta
fluid?
test.
Yeah,
The what?
The Revolta test.
I've never heard this.
Oh my gosh. Okay, it's not important.
I only learned it for NAVLI. That is correct.
It was a NAVLI thing. You take the FIP fluid, you put a drop into acetic acid, and if it congeals and like sinks to the bottom as a drop, then it's densely proteinaceous and more likely to be FIP. And if it just kind of like disperses, then it has a lower protein content and like floats away, and you have some kind of like transudate that is less proteinaceous.
That's cool.
Yep.
Can you substitute
And-
balsamic vinaigrette
And
for
Sharon
that?
mentioned in the chat, it doesn't have to be acetic acid.
Vinegar.
Yes, Sharon mentioned it can just be something acidic like vinegar.
There you go.
Drop
Gillian.
it in.
Wait, I missed it. Say it
It
again.
can just be any kind of acidic,
Okay.
like vinegar. It doesn't have to be acetic acid.
Okay.
Live in the morning after bed.
Okay. Anyway, I imagine that if you were to take fluid out of the vitreous and then drop it into acetic acid, you would get a similar sign. Okay, so we're actually going to practice the thing that Ryan taught us, where we make two windows, and then the second window, hopefully I'm doing this right, because yeah, I did so great. Okay. So, and then I'm going to end up making this one go away. But for now, I just want to be able to show you both of these things. So the gross and the histo correspond really nicely. You can see this is the detached retina here. Here is that big ocean of proteinaceous fluid that's very densely eosinophilic, but also extremely acellular. So this is all fluid. There's no actual cellular component to this. We've got the lens, the cornea, the anterior chamber, the poor little squiggly iris and then the poor little collapsed iris. And now I'm gonna make this guy go away. We're just gonna look at the globe. So I didn't actually tell you any information about this because I got real excited about the gross. But this was a 4-year-old spayed female Cocker Spaniel. And she presented 2 months ago for blepharospasm, hyphema, and epistaxis. She is Ehrlichia canis positive, which is useful information for us.
Cool.
And then she progressed to having buphthalmos, hyphema, glaucoma, and blindness. They didn't tell us anything about the other eye, unfortunately. And we didn't see anything grossly that we felt couldn't already be described histologically. So we don't have anything about gross findings here. We do have a lot of very nice annotations. If you, sorry. Okay, that's fine. If you mouse over the annotations, you don't have to click on them in order to see what they say. But if you do click on them at this, okay. Well, I was going to show you how like they take you to the actual annotation at the right magnification, but the first annotation just takes you to like the subgross, which we already discussed. So this is the proteinaceous fluid. Let's do one where it actually takes you down closer. I think the Piffum will do it. Whee! Okay. It's like a roller coaster ride. So there is a pre-iridal fibrovascular membrane that is lining the iris. When we click on the annotation, it takes us nice and close. And then you can also see, like in Gillian's case, how that is adhering to Descemet's membrane in the posterior cornea, and that's resulting in peripheral anterior synechia. Okay, but let's look at the more salient features of this case. So over here, we have got a box that's outlining the ciliary body. So we've got ciliary body kind of going all the way basically out until here, and then it kind of ends. And there are some ciliary plica here that look pretty okay. And then we've got this area that looks not okay at all. And there is like total loss of architecture here and just free pigment because there is necrosis of the entire ciliary plica here. And I think I can click on this. Yep. So uveal necrosis, necrosis of one of the ciliary plica, and like the note says, this is something that we look for in cases of hyperviscosity syndrome, is necrosis of different areas of the uveal tract. A lot of times it's the ciliary body. It can also be the iris, or we're getting to the retina. Retina is not the uveal tract. Gillian's trying to spoil the ending. It's okay. So then we've got the detached retina, which we were able to appreciate grossly. And as you can see, this is the retina. It's just a fine little barely hanging on fiber of a retina. If we go closer, like these are retinal cells of some kind, probably. But there's just, do you say retinocytes?
Yeah.
Yeah. They have mostly lost their identity. Maybe here's some of one of the nuclear layers, hard to say. The point is there's a lot of atrophy of this retina and most of the retina is lost. If we go over here, the little wheelie guy is not something that I should be trusted with. And we click on this guy. We already talked about how the retina is detached, but this annotation is describing the retina being jumbled. I think it's actually easier to appreciate in places like this, where you can see like here's a ganglion cell, here is a nuclear layer, possibly the inner nuclear layer, but there's kind of a complete lack of organization associated with the fact that the retina is detached. And then if we go down here, we have areas of complete retinal necrosis. Oh, well, this is an area of hematoidin pigment, apparently, but we'll look at that. But it's associated with these areas of retinal necrosis. So hematoidin is bright yellow, and it is an earlier breakdown product of hemoglobin. So as the hemoglobin breaks down, it becomes hematoidin, as well as hemosiderin, which is more of a golden brown color rather than bright yellow. And this is going to be this kind of more brownish. Some of this is going to be hemosiderin. There's also probably melanin in here, presumably from the RPE, as well as the general uveal necrosis that we've got. But all that being said, I'm gonna look for, I really thought that there was a retinal necrosis.
I really struggled convincing
tag,
myself
but-
retinal necrosis in this case, in the sense of like finding good, like necrosis of nuclear layer. Like I believe there's retinal necrosis. I just don't know if it manifested well histologically on this slide. If you see a different spot, I will add it.
That's fair. I think that we have like, I think areas like this, like we have loss of architecture and loss of like elements of the retina. And I guess I understand what you're saying. Ryan's saying he doesn't see areas of like active necrosis where we have obviously like pycnotic or karyorectic nuclei. I would argue that like areas like this represent necrosis because we have loss of tissue and then replacement with hemorrhage. But yeah, I would agree that like there aren't great areas in the section of the retina nuclei becoming fragmented and completely destroyed. But I think that like all of what we see is indicative that like necrosis had to have been present. And I think that areas like this, like the architecture is gone, right? It's
And
just
you can see
like
the vessels remaining there, so you know that.
yeah, Leandro's got a great point. You can see that there are vessels here still, retinal vessels, and then the tissue surrounding them is mostly lost. So I would call that necrosis comfortably, but I think it, depending on who you are as a pathologist, your mileage may vary, especially depending on where you were trained. Some places are more aggressive about calling necrosis than others.
As an aside, for folks who are super familiar with Coplowisms, you can actually have development of a fibrinoproliferative lesion associated with hyperviscosity syndrome and retinal necrosis. So don't be confused. If you see what is an accumulation of fibrin with blood vessel or vascular channels in it in an area adjacent to or associated with an area of retinal necrosis, that is a fibrinoproliferative lesion. We often associate that with systemic hypertension. But in the cases of hyperviscosity syndrome, it's more associated with the poor perfusion, retinal necrosis, and then the reaction of vascular growth associated with that. So carry on.
Okay. Okay, so Gillian kind of stole the ending of my story a little bit, but that's okay.
Again,
Sorry. She's just so excited to talk. Don't worry, you'll get to talk some more. So your main differential when you have retinal detachment, retinal necrosis, uveal necrosis, intraocular hemorrhage, your main two differentials that we think about are going to be either hyperviscosity syndrome or systemic hypertension that is then manifesting in the eye with significant vascular changes. In this case, we have a lot of clues that help us favor hyperviscosity syndrome. One of them is knowing that the dog has an Ehrlichia infection. Basically, the things that predispose a dog to having hyperviscosity syndrome are things which cause either an increased cellularity in the blood or an increased protein, particularly large, bulky shaped proteins like IgG or IgM. So conditions that we think of are things like Ehrlichia infection or Leishmania infection, also things like multiple myeloma or some leukemias, which are going to be, multiple myeloma obviously is going to be adding protein to the blood. Some leukemias, those are going to be adding white cells to the blood. So all of these things end up increasing the viscosity and turbidity of the blood. That causes shear damage to the blood vessels. And a whole bunch of other issues. Obviously, if you have proteins, then you're going to have proteins precipitating, and then you can end up with hypersensitivity to those depending on how the condition progresses. So all of that said, these are kind of common causes that we think of for hyperviscosity syndrome. And the thing that clues us in histologically is this really densely proteinaceous exudate. When you have systemic hypertension, you have all that hemorrhage, you have the retinal necrosis, the retinal detachment, the uveal necrosis, but the serum that is associated with the hemorrhage shouldn't be this densely proteinaceous, which is manifested histologically as this really, really bright eosinophilic fluid. It should be sort of more, less pink, still pink, but less vibrant, less magenta-y, more, I don't know my colors of pink. think of a color that's less magenta and more light pink.
There's a case of systemic hypertension in here too, if you just want to show the difference.
Yeah,
So
let's just
below
do
where you
that.
are, there's a lot more hemorrhage associated with it.
All right, so here's a case of systemic hypertension. To make Leandro less uncomfortable, we'll rotate it so the cornea is straight up. So once again, we have all of this intraocular hemorrhage. The retina is detached and necrotic. This part is the viable retina, and this part is the necrotic and gone retina. But then the serum that's associated with it is more lightly eosinophilic. There's also a lot of, we can zoom in on this area, but there's a lot of fibrin associated with it too. But this is just in general. Whoa, I rotated it. That was a mistake. Now we are all seasick. All right, let's stop doing that. Okay, so here's a good example. There's a lot of fibrin in here, which is kind of clouding our interpretation, but you see the hemorrhage, and then you see this lightly eosinophilic background. This is a serum that's less densely proteinaceous and more like regular serum, I suppose you could say, in contrast to what we have with hyperviscosity syndrome, where it's really, really bright and magenta. Okay, with that, I think I'm gonna let Ryan give closing remarks, or Gillian give closing remarks.
Before we
Oh, Leandro wants to give closing remarks.
finish that off, a good trick to do is a PAS or an ocean blue PAS in some of those cases. For some reason, I cannot explain the biochemical reason for that, but the fluid here in hyperviscosity syndrome tends to pick up PAS, so it becomes magenta, as opposed to the fluid you see with just regular hemorrhage, which doesn't, so it just highlights it, and it's very repeatable. It's almost like it happens in almost every one of them. So
Also,
you carried out. Go ahead. Talk about vessels.
yeah, I have a couple more points to add for hyperviscosity syndrome. So, first of all, if you're trying to decide between hyperviscosity syndrome and systemic hypertension, look for abnormal vessels, i.e. like hypertrophied media, tunica media, and things like that, or atherosclerosis. If you find vascular lesions, chances are it's not going to be hyperviscosity syndrome. Oh, sorry, it's not, not hyperviscosity syndrome, but instead systemic hypertension related stuff. And also with hyperviscosity syndrome, the stuff that's leaking out of the vessels that's high protein is the same as the serum that's in the blood vessels. So if you go to the choroid in particular and find blood vessels, and I'm not sure if it's in this case or not.
This case didn't have great ones. I
Okay.
presented this case for MIVP, but we can look.
Yeah.
This is
So sometimes, well, that's actually a good one right there. So the hue of the serum in that blood vessel right there is similar to the hue of the protein that's in the eye.
And you pick up the PAS too in the vessel.
So that is an indication that whatever's in the vessels is high protein, i.e. higher protein than it should be in this case because of Ehrlichia canis and probably immunoglobulins. And then it's a similar consistency of what has leaked into the eye. Now, you can have high protein intraocular exudation when you have severe intraocular inflammation. So for example, if you have a really severe lens-induced uveitis, or you've got a fungal infection and you've got a lot of leaky vessels because of that, you will actually get accumulation of high protein exudate in the eye, but the stuff that's in the blood vessels probably is not going to be the same consistency or the same hue. So you have to be a little bit careful with that. That's why it's nice to be able to look at the choroidal blood vessels in a nice case like this, and say, oh yeah, that serum is way too pink. And once again, that comes with looking at a lot of cases. And obviously this one came with a helpful history. So that was obviously very helpful for making this diagnosis. And with that, I'm done. And it's 9 o'clock.
I do want to say, just bear in mind, there are other causes of hyperviscosity syndrome than just high protein in the serum, because you can have hyperviscosity syndrome caused by really high either red or white blood cell elements. And it's more commonly recognized in human medicine, but just bear in mind, like This, what we're showing you, is hyperviscosity syndrome caused by hyperproteinemia, but you could also have hyperviscosity syndrome caused by leukemia. And then in that case, we're not going to see this like really beautiful protein-rich exudate within the vitreous. But you
Polycythemia vera, for example.
exactly. Yeah, exactly. And so you can still see a lot of the manifestations of uveal necrosis because you're causing damage and occlusion of the blood vessels and retinal detachment, but you're not going to see this really bright eosinophilic material in the vitreous or in the blood vessels. Okay, and with that, I think we're done. Ryan, do you have anything else?
No, that's everything. Just to mention, I did put a fibrinoproliferative lesion in this case of hyperviscosity. So one of the annotations is what I believe to be a fibrinoproliferative lesion that Gillian mentioned. And then also, if you refresh it, I just added an annotation for retinal necrosis.
Okay.
So it should be an area now when you refresh the screen that there's something for
Do
retinal
you want
necrosis.
me to do that? Do you want
Oh,
me
no,
to
you don't have to. I was just letting everyone know.
Being updated
And
live, real-time updates.
yeah, that's everything. If you guys have questions, email Coplow. If there's something they're not sure about of like navigating it, they'll probably forward the email to me. So with that, enjoy the Atlas once the link gets posted.
All right, sounds great. Thanks everybody for showing up and learning with us. And we will see you next time.